things that are not average would be considered abnormal. Okay. Psychologists and society in general don't base their ideas of normality and abnormality on things like a statistical average of things. They would look at it as things that are valuable are normal. That's good. We're fine. We don't have to worry about that. Okay. So we have to look at it as the definition of normal and abnormal in a different way, because statistically isn't very good or very good definition for us. So we look at the adequacy. Okay. How are we able to function in society? Okay. That's another way that psychologists define normal versus abnormal. Okay. People would be labeled as abnormal every single time they couldn't fulfill their ability to do something or their role in society. That's a pretty good definition unless you're having a particularly bad day. People have bad days all the time. It doesn't mean that they are abnormal. Okay, they do not have an abnormal problem. Okay, so we have to look at things in another way. Okay. Also, another way to think about it is you might be getting B's in high school, but you might get D's in college. Doesn't mean that you're inadequate. It just means that you weren't particularly well prepared or ready for the next level. Okay. Your ability to be normal or abnormal hasn't changed, but the qualifications of what is now adequate have. Okay, so if that's not a good definition, let's look at discomfort. Okay, if a person feels distressed or unhappy, we might label them as disturbed. Okay, others might not always notice a person's distress. Okay, so this isn't a particularly good way of defining what is normal or abnormal in the world of abnormal psychology, because people could, theoretically at least, hide their true emotions. Okay. How many times, and this is of the four of you, how many times have you been in a situation where you have had, maybe you have suppressed or, made it not seem like you were having a bad day so that people would just leave you the hell alone? Has that happened? Once every other day. Has that happened for those of you who are at home? Is that something that you have done? Now you know the stress of being an online teacher. Yeah, oftentimes. Okay. It's something that we experience and we try to kind of hide because we just want to be left alone. Well, if personal discomfort is our definition of what is abnormal, if somebody is abnormal and is having a mental health issue, we might not see it. Okay. They might conceal those emotions to appear to be more normal. So, what about bizarreness? That might be another way of being able to define what is normal or abnormal. The problem with that is that there are a lot of things that we find to be bizarre, strange behavior, people who acting very differently. Maybe they're having auditory hallucinations. Maybe they have an intense phobia. Maybe they have severe memory loss. But maybe they're just weird. Or maybe they fall into that last category. Maybe we as a culture see it as weird. Okay. The cultural model of normal versus abnormal depends upon the standards set by a particular culture. Okay. For example, our society, okay, here in the United States and through most of the Western world, views the idea of a sexual relationship with a child to be horrible and abhorrent and abnormal. But there are other places around the world and other cultures that are not, quote unquote, mainstream in our society that sees that as not only normal, but perfectly acceptable and encouraged. Okay. That can't be our definition of normal versus abnormal, because then there are going to be a lot of things that would be considered abnormal in a sense. But in each of these cases, we have seen the field of psychology define what is normal and what is abnormal. For example, back in the 1970s, psychology defined homosexuality as abnormal behavior. Okay, they said that was something that was, you're mentally ill if you are gay. Okay, that was written into the book, which is we'll talk about here in just a second. Okay, that was taken out when people started going, well, it's not a mental health issue, it's just a personal preference. It's not a thing. And so they eventually took it out in the latter half of the 1970s. Okay. So being defined as abnormal or normal can be a very large deal for people to deal with on a daily basis. Because if you get labeled as abnormal or having a mental health issue, you could be involuntarily committed to a mental institution. You could also be denied access to a job. Okay. It was illegal for gay people to be teachers in the 1970s because you weren't allowed to have a mental health problem. So if you were gay and you were a teacher and they found out that you were gay, well, that you have a mental health issue, you're mentally ill, you're fired. That was what it was. Okay. So this is a major problem of how we define what is abnormal in the field of psychology. And each one of these has to be kind of thought about, whether or not you are statistically outside the norm. If you are able to function properly and able to do your daily tasks, take care of yourself, do your job, take care of your family if you have one, et cetera, et cetera. Your own personal discomfort. If it's not bothering you, then it's not really an issue, is it? Maybe you have an intense phobia. Okay. And we'll talk about those in just a couple of minutes. But maybe you have a huge phobia that you don't know what to do with. If you do know what to do with it and you can deal with it, then it's not a problem. And your personal discomfort isn't an issue. But if it becomes a problem, then it can be. The absolute bizarreness of a person's behavior. For some people, they are rich and bizarreness is not really an issue. It's just a quirk. Just how that works. And then cultural issues also have to be considered as well. All right. So what is the way that we define normal and abnormal in the field of psychology today? This book, The Diagnostic Statistical Manual of Mental Disorders. Now, we have, over the course of its existence from 1952 until today, basically rearranged the book 5 different times. We are now on DSM-5. Okay. The reason why I have a picture of DSM-4 is because the textbook that we used to use didn't talk about DSM-5 because DSM-5 came out just a few years ago. And our textbook just didn't have it. But we got new psychology books. Hey! Yeah! New books after 20 years that you don't get to touch because it was just a pain in the butt. We got them in December. And I'm like, they're like, do you want to pass them out? No. Just keep using the book that we've got right now. So, in 1952, psychologists from the American Psychological Association, the APA, they got together and they basically said, look, we need a way of being able to diagnose people because we could have one therapist diagnosing a person as schizophrenic and another person diagnosing that same person as bipolar. We need to basically clarify and standardize our diagnoses if we are going to be taken seriously. So they standardized it by creating the DSM, the very first DSM, DSM-1 in 1952. Up until 1994, it was revised 4 other times, which is why we call it DSM-4. And just a few years ago, we redid it again, and we produced DSM-5. Now, the way that the DSM works is that each entry is considered a mental illness. Okay. And they have classified each mental illness into a very, very categorized way. And they have also classified them into what the symptoms of each disorder looks like. They also characterize what a person with it looks like versus a person that has something similar. You're going to have an opportunity of being able to do something like this in the next couple of weeks, because we're going to give you the opportunity of being able to create a DSM entry. And we're going to do it for a very specific disorder that many of you might be suffering from. We'll get to that in a couple of days. Okay. So each DSM listing describes both the essential and the associated features of the particular disorder. That way, each and every single psychologist around the United States can look at it and go, let's see, they've got this symptom, and this symptom. Oh, they have bipolar disorder. Or they have this one, but not this one. It could be, but they do have these secondary ones. Okay, we can figure out exactly what kind of diagnosis a person is going to receive. Okay. That way, it reduces the chances that a person could be described as schizophrenic by one psychologist and bipolar or, panic disorder by another. Okay. So let's talk about some of these symptoms and some of these disorders. And again, you don't have them. You're right, I don't. But don't self-diagnose, okay? Do not self-diagnose. That's not okay. Okay, one of the big things that the APA says is self-diagnosis is not an actual diagnosis. You can say, hey, I might have something like this, but you need to go to a different trained therapist and psychologist or psychiatrist to be able to get that thing. A psychologist goes through and gets a degree in psychology. A psychiatrist gets that degree in psychology and then goes and gets a medical degree on top of it. They go to med school. Okay. That is a lot of schooling, but a psychiatrist is a person who can prescribe medication. Okay, a psychologist can't do that. They can look at you and say, look, you have all the symptoms of bipolar, but they cannot give you the meds to help treat it. They have to then refer you to a psychiatrist who will then okay the diagnosis and then write the prescription for the medication. So that's the main difference. Okay. A therapist goes to psychology or goes through school and gets a degree in psychology. A psychologist does the same thing. They're kind of interchangeable, therapist, psychologist. Depends on what they want to be called. But a psychiatrist, they go on to med school and they are the ones, they get paid a lot more too. Yeah, they make a lot more money typically than your average therapist or psychologist. A psychiatrist will go on to work at a hospital typically, and they'll be well into the 6 figures. Whereas a psychologist may or may not be able to open their own practice. It's a whole thing. Okay. But that's basically the main difference between them, for those of you who might have been wondering. All right. So our first set of disorders are going to be centered around anxiety. Okay. Anxiety disorders are extremely common. Okay. About 15% of adults suffer from symptoms of an anxiety disorder at some point in their lives. Probably, actually, right now, 15% of adults are experiencing anxiety disorders. Anxiety disorders are also disorders that have exploded in the last year. Why? Because we're all locked in our houses, scared to death that we're going to die of a disease that we have little to no control over. Okay, so some of the main characteristics of anxiety disorders include excessive fear, okay, and worry, mood swings, headaches, weakness, fatigue, or just this underlying feeling that you're in danger, okay? So in truly dangerous situations, fear is a good thing. Fear is something that we need in dangerous situations. If we feel like we are not in danger, we can kill ourselves by accident. Okay. If I didn't feel fear around gunpowder, I could blow myself to pieces. If I didn't feel fear near the edge of a cliff, I could slip, fall, and kill myself. If I didn't feel fear, walking down an unlit street at night in a dangerous neighborhood, I could be jumped at any moment. Okay. Fear is a good thing until we start experiencing excess amounts of fear for no apparent reason. And that's what this set of disorders is all about. Unrestrained and uncontrolled fear. That's anxiety. Again, do not self-diagnose. But anxiety disorders are extremely common. Okay. So, what are some anxiety disorders? Well, there's a couple of them, and we're going to talk about each one of these in more specific detail, but kind of a quick run through of some of the disorders. We have generalized anxiety disorder, phobic disorders, panic disorders, obsessive compulsive disorder, and post-traumatic stress disorder. All right. So let's talk about generalized anxiety first. Generalized anxiety is basically characterized by panic attacks. Now, a panic attack is really, really unpleasant. Now, for those of you who have experienced a panic attack, you can attest to this. But basically, it feels like you're having a heart attack. You have chest pains, you're having some trouble breathing, maybe you're shaking a little bit, you're having some trembling issues, and you just have this feeling of something isn't right, but I don't know what it is. Okay. Generalized anxiety also is characterized by difficulties making decisions or troubles with your family. It can also include physical complaints, physical symptoms of a loss of appetite or indigestion. Generalized anxiety could also create problems with your digestive system and cause you to suffer from diarrhea or constipation. It could also lead to breathing problems. You might start suffering from asthma attacks and things like that more and more. I don't want to say openly, but more quickly you can suffer from these things. So all of these things kind of lead to this idea of generalized anxiety disorder. Now, generalized anxiety disorder is basically the feeling that something is wrong, but you don't know what. You want to fix the problem, but you don't know how. And that feeling leads to the panic attacks. Okay. Now, I tell you not to diagnose yourself because, what was it? It was about, I want to say about 4 years ago. 4 years ago, I was basically an undiagnosed generalized anxiety patient. Okay. Every single night I would drive home. And every single night I felt like I was having a heart attack. It was a heart attack in slow motion. I just felt like somebody had their thumb right in the center of my chest, and they were just ever so gently pushing me into my seat. I had a lot of stress going on in my life at the time. My wife was, at that point, 8 months pregnant. My classes were going horrifically bad. My AP US history class, my psychology classes, all of those classes were just, I didn't feel like I was doing my job well enough. My wife, for all of her positives, was also trying to find ways of, not having so much stress. And so she would do things that would basically stress me the hell out. Like we had to go, she is a big fan of the band U2, and U2 came and did a concert at the Rose Bowl, and she couldn't go. She bought tickets and then couldn't go at the last minute because her job basically said, no, you have to go to North Carolina for a couple of days. And so she couldn't go. So the next time they came, we had to go. And I had to go to work. And so the second I got done with work, I got in my car, I rushed home. And the entire time my wife is tapping her watch going, we need to be leaving by now. And I'm like, I'm almost home. Just give me a second. I get home. She immediately gets in the car. Let's go. And basically the entire drive to the forum in Inglewood, she was, tapping her watch going, we're going to miss the show. We're going to miss we're going to miss it. And I'm like, when was the last time a rock and roll band started their show on time? Well, they said 6:00 and it's already 5:30 and we're going to be late. Stressed the living bejesus out of me. We get there at 6:00. We get in, we get to our seats. And guess what? They didn't start on time. Okay. So it was a real big stress that was put on me at that point. I was under a lot of stress. Everything was very, very stressful for me. Okay. And I was experiencing these panic attacks in slow motion. That's basically how I would describe it. I didn't feel like I was having, trouble breathing or anything else like that. It didn't feel good. Something wasn't right. But that's what a generalized anxiety basically feels like. You're kind of having a disorder happen to you while it's happening. It's the weirdest thing. I kept looking at myself in the rearview mirror to check to see if I was turning gray, to see if I actually was having a heart attack. That's what I kept having to do to myself. I eventually went and got myself a diagnosis, and they're like, yeah, no, you've got generalized anxiety disorder. Oh, great. Can we treat it? They said, well, here's some things that you can do. And they definitely did help. Okay. But that's generalized anxiety. Okay. It's just that feeling of something's not right. And you can suffer from panic attacks. I actually had I don't want to say a full blown panic attack, but I actually had a panic attack at a movie. Again, my wife, wanting to de-stress me, decided that we needed to go see a movie. All I really wanted to do was sit down at home and do nothing. But no, we're going to go see a movie. And in the middle of the movie, in the movie theater, I started feeling that panic attack coming on. I just started feeling really warm, like it was really hot inside the movie theater. And my wife had gotten me a watch, and it measured my heart rate. And I remember checking the heart rate, and it was at like 130. Which is like a heart rate for somebody that was running a marathon. And I'm sitting there going, I've been sitting down for the last hour. How do I have a heart rate of 130? which just kicked in the generalized anxiety and the panic attack even further. I didn't end up seeing the end of the movie. And after the movie was over, because my wife stayed and watched the rest of the movie, we went to the hospital, and I sat in the emergency room for a little while. And that's when they were like, yeah, you're having a panic attack. Have you seen somebody about this? No, I'm having a panic attack. Is that what it is? It's a panic attack? Okay, so I'm not having a heart attack. I'm not dying. No, you're not actually dying. Oh, good to know. Good to know. Thanks. Thanks a lot, Doc. Appreciate it. Okay. So that's kind of my experience with my own generalized anxiety. Another type of anxiety disorder that's out there, and this is a very common disorder that most people have, at least one of, is a phobic disorder. Okay, now, when I talk about phobias, we all have phobias. Some people don't like spiders, some people don't like snakes, some people don't like heights, some people don't like water, whatever, okay? A phobic disorder, on the other hand, is a severe anxiety about a particular object, animal, activity, or situation. Okay. Now, the best example that I can give to you was I had a student several years ago. God, she graduated. No, not several. I'm talking like she graduated in 2007, I think. Maybe even 2006. It was a long time ago. I had a student who was severely arachnophobic. She had a severe phobia of spiders. Now, I'm sure some of you are like, oh, I don't like spiders. I have a phobic disorder. No. This was a phobic disorder way beyond anything that I'd ever seen before, to the point where somebody drew a spider on a paper of hers and she began having a panic attack. It wasn't even a very good drawing of a spider. It was a very bad drawing of a spider, and it freaked her out. Okay. The one thing that I do remember is that she sat back against the back wall when you could do that. And I remember watching a spider crawling down the wall. And when I looked up and I saw it, I went, oh, this is not going to be good, because it was crawling right towards her. And I'm like, oh, this is bad. How do I tell her? Because I can't say the word spider, because even saying the word spider caused her to tense up and freak out. So we had all agreed as a class to say the word cookie instead of spider, so that she wouldn't know what was going on. And I remember she was sitting next to a friend of hers, and I looked at her friend and I'm like, Nicole, do you see that cookie? And Nicole kind of looked at me like, what the hell is he talking about? Cookie? Where's the cookie? I said, the cookie. And it took her a second before she went, oh. And then she realized what it was, and she looked behind on the wall, because I was kind of nodding toward it so that I wouldn't freak her out or the other girl out. And she looked up and she's like, hey, Sarah, why don't we go over here? And she kind of got her to stand up, and Sarah didn't know what was going on until it dawned on her, cookie, there's a spider. She freaks out. Her entire body kind of tenses up, and she bolts for the door. Okay, that is a phobic disorder. Beyond just a simple phobia, oh, I just don't like heights. No. That's not a disorder. This is something that affects your life. Okay, it is severe. It causes panic disorder or a panic attack to happen to you. That kind of phobic disorder. Okay. And again, and I should have mentioned this at the beginning. If at any time we talk about something and you're like, yeah, that's me, I've got that, feel free to share, but don't if you don't want to. If you're not comfortable with sharing that you have one of these disorders, you don't have to. I'm not saying you do. But if you do happen to have something like that, and you want to speak up and say something about your own personal experiences with them, please feel free. Please feel free. Okay. But again, we all have those little things of, I just don't like, I don't like Jello because it just doesn't seem right. I don't like it. I'm not afraid of it, but I just don't like it. But there are people out there who have a death fear of Jello. They just don't like how it jiggles. I know we all have our own little phobias. Okay. No judgments from me. And I'm sure somebody in this, either in this room or in this room, are sitting there going, yeah, I don't like Jello because it jiggles weird. I don't like it. No judgment. You do you. Okay. All right. So that is a phobic disorder. Again, way beyond just a phobia. This is something that is crushing to you. Okay. Panic disorders. This is basically a panic attack. A panic disorder can happen just kind of out of nothing. You just suddenly feel helpless terror and impending death or doom, and you get that smothering, choking, faintness, difficulty breathing, nausea, chest pain. All of those problems just happen out of nowhere. Okay. Generalized anxiety is you feel kind of dread about something. A phobic disorder is that there is a specific thing that triggers it. A panic disorder just can happen out of nowhere. Just suddenly, I'm having a panic attack. Now, when we talk about treatments in a couple of weeks, we can kind of understand some of the things that we have to kind of consider when it comes to these kinds of disorders. But understanding what we are experiencing can help to mitigate some of those feelings of impending doom, death, dread, terror, panic attack. Okay. So the next, a favorite disorder of many, many people, obsessive compulsive disorder. Now, the problem that we experience in psychology oftentimes is that people will, I don't want to say fall in love with the disorder, but people tend to kind of romanticize, oh yes, obsessive compulsive disorder. I knew a person with this, or I have this, or people start making jokes about it. Obsessive compulsive disorder is not something that is hilariously funny, which it oftentimes is in sitcoms and TV shows and movies. Oh, it's so funny. Look at he's got such panic disorder. He's got such I'm so obsessive compulsive. No. You really have to understand what it is to be able to say, yes, I have OCD. Okay. Now, obsession is where you think the same thoughts over and over and over again to the point where you can't break it. You can't stop that train of thoughts. Once it leaves the station, it just keeps going. That is an obsession. And you can have an obsessive thoughts about almost anything. Okay. So it starts with an obsessive thought train. What obsessive compulsives do is they try to stop the obsessive thinking by performing irrational acts because they are compelled to do so. Okay. So an obsessive compulsive is the thought train starts. And so they start doing these little rituals to stop the thought process from happening. Okay. Now that thought process can be almost anything. That thought train that leaves the station and can't be stopped could be almost anything. It could be thoughts of your family coming into danger. It could be thoughts of yourself coming into danger. It could be thoughts of the end of the world. It could be thoughts about almost anything. And those are unpleasant thoughts that we don't want to have. So an obsessive compulsive will start performing a ritual that they have created, usually surrounding a number or a number family that they have to do in order to stop the obsessive thoughts. Okay. So what does that mean? Well, I actually met a person who was a diagnosed obsessive compulsive. They were obsessed with the number 3. Their obsessive thoughts centered around them becoming ill. Okay, they were going to become sick in some way because of something that was happening around them. They just couldn't stop fixating on that unless they applied the salve of thinking about doing things in 3s. Now, this person that I knew, I worked with at a restaurant. Okay, I was a busboy. Okay, I bussed tables, I cleaned tables after people left. Didn't steal tips because didn't need to. Servers tipped out at the end of the day. Wow, was that fantastic. Anyway, so worked with this girl who was the hostess, okay, the person who sat people at the tables. And the way that I found out about her obsessive compulsive was one day I was taking my lunch break, and she came into this back room where I was having my lunch, and she proceeded to set down a bunch of napkins on the table. And I looked at her. I said, why are you putting napkins down? I wiped the table down. It's good. It's clean. We use bleach. Can you not smell it? I can smell it. It's on everything. I smell bleach everywhere. And she's like, no, it's not. I know you cleaned it. I know you're using bleach, but I have to put these down. What do you mean you have to put them down? If I don't put them down, my food will be contaminated. And I looked at her, I said, what? Your food's going to be contaminated if you put the plate on the table? Yes. I can't put the plate directly on the table. Otherwise, I can't eat off of that plate. It'll be contaminated with germs from the table. I said, you know that's not how germs work, right? And she's like, yes, I know that, but I can't eat if I get it from the table. Okay. And that's when she started talking about her obsessive compulsive disorder. She had to lay out 3 napkins in a very specific pattern because that protected her plate from the germs on the table. When she walked into a room, she had to turn the lights on 3 times. And when she left a room, she had to turn the lights off 3 times. Otherwise, she would be contaminated with the germs that were in the room. Okay, it was an obsessive thought about germs that she was having over and over and over again. And in order to get those thoughts to go away, she would perform these little ritual tasks for herself. Okay, when she sat people, the first table that she sat for the day was at table 3. If somebody was already at table 3, then it was table 6. And if someone was at 6, then it was at 9 and 12 and 15. And she would go until she got, a number divisible by 3. That was always the first table that she sat. Why? She didn't know why, but it made her feel better. That's obsessive compulsive disorder. Wanting to have things a certain way or being clean or whatever. That's not obsessive compulsive. Obsessive compulsive can ruin a person's life. And it can ruin it because the obsessive thoughts and the compulsive acts become disruptive of your daily tasks. There was a TV show on, I think it was on A&E. You might have seen it. I don't know. But it was, what was it called? It wasn't the Hoarders show. I can't remember. Anyway, there was this show, and I remember I watched one episode, and they talked to 2 different obsessive compulsives. The first was this guy who, every time he saw an El Camino, which is a car that has a pickup back. So it's not a pickup truck. It's a car that has 2 seats and then a truck bed behind it. They were really popular in the 60s and 70s, and then they just disappeared because that's the dumbest thing I've ever heard in my entire life. Okay? Why would you get a car with a pickup bed when you could just get a pickup? It doesn't make any sense to me. But this guy had obsessive thoughts about them. He thought that they were bad. They were bad omens in his life. And every time something bad happened to him, it was because of an El Camino that had just driven by. It was kind of like the idea of, a black cat crossing your path, except it was a car. And it was a particularly rare car. Anyway, this guy had to wipe off an El Camino. And so his compulsion was basically to sit there and do this with his hands for 15 or 20 minutes. And he couldn't move until he did a certain number of those hand wipes. And he would just sit there doing this, obsessing and obsessing and obsessing and obsessing, and doing the compulsive acts. If he had a particularly bad day, wiping off the El Camino wasn't enough. He had to go and stand in the northwest corner of his apartment and wipe off the Camino, and then go do something else, and then come back and stand in the northwest corner wiping off the Camino. He didn't know why he had to do it, but he had to do it. It basically made it so that he couldn't hold down a job, because if he were on his way to work and an El Camino were to suddenly, come into, his view, he had to stop what he was doing, which was going to work, and he had to go back home and do all of those acts over and over and over again. That is obsessive compulsive. Okay. Now, where does it come from? We have absolutely no idea. What we do know is that there could be a genetic basis for it. Now, that does not mean if your parents have it, you're going to have it, and you're going to be obsessive compulsive too. Typically, what that means is that if your parents have it, you have a higher likelihood of developing that same disorder as your parents. Okay. And that's true of a lot of these disorders that we're talking about. If your parents are obsessive compulsive, there's a higher chance that you're going to be. If your parents have a depressive disorder, there's a higher chance that you're going to have a depressive disorder. If your parents have panic attacks, there's a higher probability that you're going to have panic attacks. It's not 100%. It's just, instead of a 1 in 100, it's a 1 in 10. So your chances go up. There's not much we can do about that. How do we treat obsessive compulsive? We're coming up with new therapies all the time, and we're also coming up with new drugs that can help people, but ultimately, we don't have a cure for obsessive compulsive. But we'll talk more about cures and therapies and stuff like that when we get to treatments. All right. Another set of disorders outside of anxiety are psychosomatic and somatoform disorders. Psychosomatic disorders involve real, identifiable physical illnesses that are caused by stress or anxiety. So you have a problem, a physical problem with you that isn't caused by anything physical. It's all inside your head. Okay. Somatoform disorders, on the other hand, there are no clue as to where these things come from. They just happen to people. Okay. And we'll talk about what those types of things are in just a second. Now, there are two different types of somatoform disorder. We've got conversion disorder and also hypochondriasis, which you might know better as hypochondria. Okay. So hypochondria, we'll talk about in just a second, but the official fancy name of it is hypochondriasis. And a lot of people are hypochondriacs. It is a somatoform disorder. Okay. So conversion disorder is very, very simple. Okay. A conversion disorder takes emotional difficulties and puts it into the loss of a specific bodily function. Okay. So something that you're going through, and then it converts it into a dysfunction of the body. Okay. There is no physical damage whatsoever, but that part of your body suddenly stops working. Okay. This, an example of this is called glove anesthesia. Now, when you suffer from your hand not being able to work, like I can't feel my hand. I feel absolutely nothing. And they come in and they're poking at your fingers. Do you feel this? No. Do you feel this? No. Do you feel this? No. You can't move your hand. But when they poke your arm and they're like, do you feel this? Yeah, I feel that. But you don't feel your hand. No, I don't feel my hand. That is actually physically impossible. Our nervous system doesn't work so that just your hand goes numb. It would be your hand and part of your arm. It would have to be because of the way our nerves function. Okay. We talked about the nerve tracks in our hand and in our arms. Okay. If your hand is numb, part of your arm will be numb too. You can't feel all parts of your arm and not feel your hand. That's not how your nervous system works. Unless you are converting those emotional difficulties into the loss of the specific body function. Okay. A great example of this is actually from an episode of King of the Hill. Okay. In King of the Hill, there's an episode where Hank walks in on his mom and her new boyfriend getting down. And he suffers from spontaneous blindness. Okay. That is, and is diagnosed correctly in the episode as a conversion disorder. He is just blind. There's nothing wrong with his eyes. There's nothing wrong with his brain. He just can't see. It is a conversion disorder. That is what that is. Okay. So if you suddenly lose control of one part of your body, your leg or your hand or your vision or your sense of smell, and your doctor can't find anything wrong with you, there's nothing wrong, then it could be a conversion disorder. Okay. Hypochondriasis is something that a lot of people suffer from. And this is where you look for signs of serious illness in all kinds of different situations. This is especially found in young adults. Okay. And it occurs equally in men and women. So it's not just, women suffer from hypochondria, men aren't. No. We both are. Okay. Both men and women are equally hypochondriacs. But basically, you take something simple and you look for a sign of serious illness. The best example that I can give of this one is something that happened to me a few years ago. WebMD is the single worst thing to ever come to the internet. I mean, it is horrible because hypochondriacs love it. Okay. And they will go to their doctor and say, Doc, I have all the symptoms of, and they will, list this excruciatingly rare disorder or exceedingly rare disease that, only 3 people on the entire planet have. And they're like, yeah, I've got these symptoms. Look, I've got this. No, you don't. Okay. A few years ago, I wasn't feeling well. I had a fever and a really sore throat. And I went to WebMD because it was late at night. I wasn't going to go to the emergency room. It wasn't an emergency, but I wanted to see what I possibly could have had. So I typed in my symptoms for, what I had, a fever and a sore throat. And it looked at me and said, oh, meningitis. Now, for those of you who don't know what meningitis is, I don't know who that is because we talked about meningitis in our second unit so many years ago. But basically, meningitis is an inflammation of your spinal cord and brain tissue. It's an infection of your brain and spinal cord. It is extremely deadly. Basically, if you don't get it treated within the first day or two, you're going to die. Or at the very least, you're going to suffer from severe paralysis. Okay. If you remember the movie Awakenings, those people had meningitis. Okay. They had viral meningitis, and then eventually they developed these neurological problems in the future. Okay. After they were done with the meningitis. Meningitis is extremely severely dangerous. And I remember looking at that going, oh my God, I'm going to die. And then I started reading up on meningitis, and I was reading and reading and reading and reading. And then it said that the best way that you can tell whether or not you have meningitis is to touch your chin to your chest. If you can't touch your chin to your chest because of pain in your neck, it's so excruciating. That's a way of being able to tell. And so almost immediately, I'm sitting here trying to put my chin to my chest like a lunatic because I want to make sure I don't have meningitis. And I'm like, okay, how far down my chest do I have to get my neck? Is this good? Is this good? I don't know if this is okay. Is this far enough? And then once I figured out I don't have meningitis, I looked at the next, thing on the list of diseases that you could possibly have, and it was strep throat. I'm like, well, I have a case of strep throat. Duh. I've had strep throat many, many times. Why? I don't know. But when I was a kid, I got it like 4 times, and as an adult, I've had it like 2 or 3. Okay? I just get strep throat every now and again. Okay? But a hypochondriac will take, oh, I got a scratch on my arm. Oh, it means that I've got hemophilia. That's what it is. I've got hemophilia. I got a bruise. I'm hemophiliac. And they'll go to their doctor, and their doctor will look at them and go, no, you're not. How do you know? We've tested you for that. Remember when you came in here last month? Yeah, but I could have developed it since. No, that's not how that works. You got a bruise. It happens. Go home. Okay. Doctors love and hate hypochondriacs. Why? Why do they love them? Because they're the ones who pay for their boats. They're the ones who are constantly going to the doctor going, Doc, I've got this. No, you don't. Couldn't you order me a test? Fine. You tested negative. You don't have this. Okay. Something also similar happened a few years later. I was sick. I had no idea what it was from. I had a sore throat. I had a low-grade fever, thought it was strep throat. They tested me, came back negative. Well, it'll probably go away, they said. Well, after a couple of days, it didn't go away. As a matter of fact, it got a little worse. And I remember I took an entire week off of school, which is not something that I normally ever do. Like I very rarely take days off because I'm usually a pretty healthy person. I mean, minus the obesity. But other than that, I remember I went to the doctor and they tested me for strep throat again. And they're like, it's not strep throat. And I remember this nurse, he came in to tell me, yeah, you don't have strep throat. And then he looked at me and he's like, do you have a lot of sexual partners? And I went, no. What kind of a question is that? No reason. And of course, my brain kicked into hypochondria mode and said, why would he ask me that? And so I looked up, what are the symptoms of HIV? Guess what? A sore throat and a small fever. And I started freaking out, like hypochondria master mode. It was really, really bad. I ended up getting an AIDS test. I don't have AIDS. Who would have thunk? I mean, besides anybody who's ever met me. So hypochondria can be very, very dangerous, especially when people will go from doctor to doctor to doctor looking for somebody who will say, yes, you are dying. Because that's ultimately what they want. They want to be dying. Why? We don't know. But they want to have that serious illness. And so they look for it everywhere. And it can lead to some very, very problematic issues with their jobs because they're always at the doctor's office. Okay. All right. Let's talk about dissociative disorders. This is where things start getting rare. Anxiety disorders, pretty common. Psychosomatic disorders, pretty common. Somatoform disorders like hypochondria, pretty common. Dissociative disorders, Extremely rare. Okay. A dissociative disorder is a group of disorders where a person experiences alterations in their memory, identity, or consciousness. Okay. And there are a couple of very well-known dissociative disorders out there that you don't have. Okay. Dissociative disorders include things like amnesia and dissociative identity disorder, or what we commonly call multiple personality disorder. Okay. The official name of it is dissociative identity disorder, or DID. Okay. So what is dissociative amnesia? Oh, God dang it. Stupid sounds. Anyway, dissociative amnesia is basically where you have memory loss with no biological explanation. If you suffer from brain damage and suffer memory loss, you don't have amnesia. If you just wake up and you can't remember something, you probably don't have amnesia. But if suddenly a large portion of your life is just gone from your memory, that would be dissociative amnesia. Okay. Typically, it is something that is used to blot out some kind of painful experience that we have. Freud would have called this repression, but today we call it dissociative amnesia. And it is extremely rare, okay? To have parts of our memory no longer access to us, that's common. That happens to us all the time. It's called forgetting. But the idea of total amnesia is extremely rare, even though you have probably seen it used as a plot device in a bad soap opera or something like that. Okay. It is exceedingly rare. So don't worry about dissociative amnesia. You're not going to get it. And you can't get it by, bonking your head really bad. Oh, I have amnesia. I don't know who I am anymore. That's not a thing. So don't worry about that. You might have a concussion, but you're not going to forget who you are and, become somebody else. That's not how that works. And another dissociative disorder that's out there that we actually have kind of altered is called dissociative fugue. Now, to be in a fugue state, you basically suffer from amnesia and then leave. So it is basically a walking amnesia. You forget and you run away. That's basically what it is. Okay. It could lead the person to establish a new identity. Okay. They'll just kind of go off to a different place. Like you might suddenly, find yourself in Salt Lake City and you don't know who you are. That's called the fugue. Okay. It's called a fugue state. The best example that I can give to you from media in a very early episode of Breaking Bad, Walter White fakes a dissociative fugue state so that he doesn't get caught for cooking meth. And basically, he wanders into a convenience store, and while he's in the convenience store, he starts stripping off his clothes, and then starts claiming, "Oh, I don't know who I am. Where am I? What's going on?" And he gets diagnosed as having dissociative fugue. We've actually begun the process of eliminating fugue as a thing, because what they have found is that whenever somebody is suffering from dissociative fugue, they have found that those people have been lying. And so they're kind of like, well, maybe it's not a thing. Maybe it's not. And so they're starting to get rid of it as a dissociative disorder. Okay. All right. It also couples all of this with the repression of their past knowledge, and it could last from days to decades. Again, it's something that is kind of looked at now as not being an actual dissociative disorder. So, kind of take it with a grain of salt. But there you go. All right. Now let's talk about the big one for the dissociative disorders, and that's dissociative identity disorder. Now, this is also sometimes referred to as multiple personality because the individual in question, the person who suffers from DID, will develop two or more distinct identities with their own way of thinking, behaving, and sometimes even speaking. Okay. At different times, a different personality might be in control. Okay, so if you were to talk to that person who suffers from DID, they might say that their name is, Kevin, and then a few hours later, you might meet another identity, and their name might be Larry, and they might be 14. Okay, there's no rhyme or reason to it. Now, a few years ago, and by a few years ago, I mean probably close to 10 years ago now, we actually had on campus a school psychologist. We still do have school psychologists on campus, but this psychologist actually had a private practice. She had her own psychology practice in, what did she say, East Texas. She was the only psychologist for miles, and so she got all the cases from around her little area. And she would come in and talk to my classes about her experiences in not only dealing with dissociative identity disorder, but also treating it. And what she has found in her experiences is that dissociative identity disorder almost always developed because of some kind of sexual abuse as a child. Okay. Now, does that mean that if you are molested as a child, you're going to develop DID? No. But all of the people that she dealt with had been abused as a child. And so that's what her experiences were. She told the story about how she was talking to somebody, treating somebody for, some kind of depressive disorder. And then, they said, "Thank you very much, doc," and went home. And then basically once they got home, one of their alternates came out and called her up and was like, "How dare you talk to them? You're not supposed to be talking to them. I'm only supposed to be talking to them. You can't talk to them. Don't ever talk to them again." And that's how she found out that this person had multiple personality. Again, DID is exceedingly rare, and some of the best known cases of dissociative identity disorder have actually been proved to be faked. And we'll take a look at one of those examples soon. Maybe Friday, maybe next Friday. I haven't decided. I have to actually figure out what we're going to be doing for this unit right now. But it is one of those disorders that is kind of, I don't want to say well known, but it's one of those things that kind of keeps coming back in like Hollywood. Movies will use dissociative identity disorder as a plot device. It's a very, very serious disorder. Okay, so don't start, "Oh yeah, I think I might have DID." No, you don't. You don't have DID. Let's not do that to the people who are actually suffering from these types of things. What was the name of that movie? Anybody remember the name of the movie?
What movie?
The one where the guy had dissociative identity disorder?
Is that Radio?
No, it was, I forget the guy's name, but he was kind of crazy and he was trying to kill people.
Oh, I went to the movies to see that. He was kidnapping girls or something like that?
I think so.
I don't remember, but I know what movie you're talking about.
Yeah. It's used as a plot device a lot of times, and we need to remember that these are actual human beings, not sideshow freaks to be pointed at and laughed at. All right, that's where we're going to stop it today because the next one we're going to start talking about would be schizophrenia, and I don't want to get into that right now. So we're going to stop there. Yeah, split. That's the one. Yeah. Yes, that's the one.